Hello, I'm Dr. Carolyn Burns. I'm a board-certified anatomic and clinical pathologist with 20 years of experience in private practice in a large tertiary care 5-hospital system located in Louisville, Kentucky. I was chief of pathology as well as medical director of transfusion and tissue services. My interest in patient blood management grew from our bloodless program, and we were engaging in active PBM initiatives until my departure in 2011. These past years, I have been working as an independent patient blood management physician advisor and educator. My role with SABM is one of the current treasurer, member of the board of directors, and editor of the newsletter. Transfusion is the #1 procedure performed in our healthcare facilities today. Transfusion has been embedded into clinical practice for decades, yet current evidence highlights the need for more restrictive and appropriate use of transfusion in order to avoid its associated morbidity and mortality. The Society for the Advancement of Blood Management, SABM, is a professional society that advocates and educates caregivers on the clinical issues associated with blood transfusion and, most importantly, how it impacts our patients. PBM includes managing anemia, optimizing coagulation, using interdisciplinary blood conservation modalities, and promoting patient-centered decision-making, all of which lead to improved patient outcomes. After viewing this short presentation, you will be able to better understand SABM's vision, mission, and message of PBM and see how you and your colleagues help shape this. The learning objectives for this presentation are to examine and explain qualitative and quantitative measures that assess true coagulation status. We will describe 6 interdisciplinary blood conservation modalities in patient blood management practice and describe methods for early and ongoing detection and treatment for anemia. Lastly, there will be an explanation of the emerging concept of patient choice and patient blood management. Optimizing coagulation implies evaluating both quantitative and qualitative measures to assess true coagulation status. We also need to accurately assess the true cause of bleeding dysfunction. This may need goal-directed therapy to correct coagulation abnormalities, and we need to use evidence-based rationale for the use of plasma, and I would also include potentially platelets and/or cryoprecipitate. Optimization of coagulation necessitates both qualitative and quantitative approaches that may affect patient care. Qualitative measures include a detailed patient history with specific questions to identify possible bleeding risk. These questions should identify any prior bleeding episodes, particularly if associated with the need for transfusion. Review of any family history of bleeding, thorough review of any drugs, including over-the-counter preparations and herbal medications, and any clinical conditions that might predispose the patient to bleeding. Assessment on physical exam might identify petechiae or bruising, which are signs of possible bleeding diathesis. The complexity of the surgical intervention or procedure should be considered as well. If there is acute bleeding at the time of presentation, there must be immediate efforts to identify the source and bring this under control. Evidence-based guidelines for transfusion should be available for all healthcare providers. Quantitative measures via specific laboratory tests to identify coagulopathy can be performed. The routine complete blood count, a protime with INR, and activated PTT and fibrinogen are the bedrock. Other tests to consider are platelet function assays and viscoelastic testing if available. Numerous point-of-care or near-care instruments can be utilized. All in all, laboratory results with adequate turnaround time assist in goal-directed decision-making and should be aligned with transfusion guidelines and other therapeutic modalities. The SABM Administrative and Clinical Standards for PBM programs provide guidance regarding the optimization of coagulation by risk assessment. The principles include minimizing blood loss through early recognition of bleeding or bleeding risk, as well as promoting the use of pharmaceuticals or factor concentrates which aid in maintaining or acquiring adequate hemostasis, thus preventing unnecessary transfusion exposure. PBM programs should also allow for appropriate referrals and consultations. Please note the interdisciplinary approach. So let's now move to a discussion of specific interdisciplinary PBM modalities. Interdisciplinary blood conservation modalities include the adoption of precise and meticulous surgical techniques using all available methods of hemostasis. We need to rapidly diagnose and promptly arrest blood loss in all clinical situations. We need to employ appropriate intraoperative blood conservation modalities in an evidence-based fashion. We need to use available intra- and post-operative autologous blood conservation modalities and use methods to measure and assess hemoglobin loss. Control of diagnostic blood loss is also recommended. There are numerous modalities available to reduce bleeding and the need for transfusion. As mentioned in the introductory remarks, this takes healthcare providers from a variety of subspecialties. Policies and procedures can help guide practice and process decisions. Education is key, so all caregivers have the knowledge and access to these available strategies. 6 primary modalities should be incorporated into every PBM program. Number 1, there should be early recognition and diagnosis of bleeding with timely intervention. Number 2, minimally invasive surgeries should be utilized to reduce bleeding risk. Number 3, controlled hypotension, adequate body temperature, and maintenance of normovolemia are important. Number 4, collection, processing, and reinfusion of shed autologous blood can also be utilized. Number 5, pharmaceutical agents, topical hemostatics, and factor concentrates should always be considered when available. Number 6, controlling diagnostic blood loss is extremely important as iatrogenic blood loss through excessive phlebotomy contributes to hospital-acquired anemia with its own associated poorer outcomes. A number of interventions are available to minimize blood loss secondary to phlebotomy. Education should be a chief element so healthcare providers are aware of the role that iatrogenic blood loss plays in causing anemia. Efforts to use small volume tubes, point of care or near care devices should be assessed and implemented when possible. Adequate training should be provided throughout the hospital system specific to the following key practices. Number 1, reduce hemolyzed, clotted, or inadequate specimens which result in additional blood draws. Number 2, eliminate the use of extra tubes, in other words, rainbow draws. Number 3, reinfuse blood to avoid excessive discard. Number 4, utilize a lab schedule, particularly in intensive care units, which will decrease the use of daily labs. Number 5, non-invasive hemoglobin measurements may be incorporated when available. And number 6, above all, solid, clear communication with the laboratory will allow for appropriate use of resources. Here are examples of small volume tubes for common tests. The laboratory should be contacted to assess availability. Our third learning objective involves detection and treatment of anemia. Identification and management of anemia is one modifiable risk that can improve patient outcomes and minimize transfusion. Processes should be in place to create methods for early and ongoing detection of anemia, enhance physiologic tolerance of anemia by minimizing oxygen consumption, employing timely evidence-based pharmaceutical and nutritional intervention to support erythropoiesis. We need to determine causes and contributing factors of anemia and ultimately apply evidence-based rationale for the use of red cells. We have noted that phlebotomy loss contributes to anemia, but what other elements are important for detecting, preventing, and treating anemia? Anemia is extremely common and has many etiologies. Clinical care providers need knowledge and experience with anemia management. Once again, a solid history and physical can provide a wealth of information to identify anemia and the contributing factors. Current literature finds at least 1/3 of patients coming for elective surgery are by definition anemic. These patients need to be identified at least 3 to 4 weeks prior to surgery to allow time for adequate diagnosis and potential treatment. Care plans are also important at time of discharge to maintain follow-up on an outpatient basis. This sustains consistency of care. General information as to the degree of anemia can be obtained from the complete blood count. More specific and sensitive studies can be used to clarify the etiology or etiologies and thus move towards specific treatment interventions. These include, but are not limited to, iron studies, reticulocyte counts, reticulite hemoglobin content, B12, folate, thyroid studies, direct antiglobulin testing, LDH, bilirubin, and serum protein electrophoresis, and even bone marrow examination if necessary. Please note in the bottom left there are 3 excellent resources which are listed. Once the diagnosis and cause or causes of anemia are solidified, appropriate interventions and treatment can be initiated. The most common etiology of anemia is iron deficiency, for which there are oral and IV preparations available for both inpatients and outpatients. Parenteral iron is used when the patient is not compliant with oral iron. There are serious gastrointestinal side effects which can be seen in 15 to 20% of patients. Patients are not able to absorb the oral iron, perhaps due to concomitant inflammatory mediators. Rapid reversal is required, and or there are ongoing losses exceeding the absorptive capacity. Erythropoietin-stimulating agents may also be needed. Vitamin C aids in the absorption of iron. B12 and folate may be useful in these particular vitamin deficiencies. The pharmacy will play a huge role in anemia management and should be included in PBM anemia management programs and PBM committees. General optimization of health and nutrition will help with absorption from natural sources of vitamins and minerals. Management of comorbid conditions is vital, as diseases such as diabetes, renal disease, cardiovascular disease, and chronic inflammatory conditions contribute to anemia and may be helped with anemia management. Anemia is not the new normal, and transfusion should not be the default for its correction. Transfusion is independently associated with significant morbidity and mortality. Serious reactions may occur with transfusion, both acute and delayed. These may be severe and even fatal. These include acute lung injury, circulatory overload, hemolytic reactions, septic reactions, iron load, and transfusion-transmitted disease, to name a few. Blood must be considered a liquid transplant, as it causes significant immune modulation and immune suppression. Thus, anemia should be corrected by incorporating non-transfusion management whenever possible. 3 excellent resources are provided in the bottom left of the slide. The 4th and final learning objective explains the emerging concept of informed choice as part of patient blood management. Patient-centered decision-making incorporates listening to the patient's needs, desires, and concerns. It also includes exploring treatment possibilities, providing the patient with correct and current information about all PBM interventions available to them. We need to inform patients of risks, benefits, and alternatives of all treatment choices. We need to integrate patient values and acknowledge their autonomy in decision-making, deciding together on a course of action, and tailoring the care plan which incorporates patient choice. And finally, we need to document and communicate the patient's preferences. Given the significant risks of transfusion, patient choice and consent is of utmost importance. SABM guidance states that hospitals must support and respect the rights of competent adults to make decisions concerning their care, including transfusion. There should also be policies that address the rights of minors. Education to healthcare providers is vital, as the concepts of informed choice and consent must be consistently delivered throughout the facility or hospital system. Choices and alternatives to transfusion, many which have been presented, should be clearly outlined, discussed, and documented. We must all remember that informed consent is much more than a mere signature on a page. Informed choice represents free selection after consideration of all options. Informed consent represents compliance to or approval of what is done or proposed by another. While the basic principles of medical ethics call for the concept of informed consent, in patient blood management and at SABM, we prefer to step beyond and use the idea of informed choice. Blood transfusion has been in a position of default for so long that many clinicians have neglected to address other options available and the modifiable risks that lead to both transfusion and poor outcomes. Patient-centered decision-making, as defined by informed choice, demands evaluation of the overarching medical condition, including coagulation status, presence of anemia, and medications. Strategies for blood conservation should be discussed, use of pharmaceuticals, and of course, thorough assessment of the scheduling, timing, staging, and complexity of any and all procedures. So, we've come to the completion of this presentation regarding patient blood management principles and clinical concepts. In summary, I hope you truly identify with the vision, mission, and message of SABM, understanding the why of PBM, or better yet, the why not. It's all about the patient. These defining principles and concepts, along with SABM standards, executive and quality guides, etc., serve as a foundation for PBM programs around the globe. This short case study offers a quick look at how PBM concepts can be incorporated into daily practice. This is a 68-year-old female with a history of hypertension, atrial fibrillation, non-valvular in origin, a family history of cardiac disease, who takes a beta blocker for her blood pressure and is well controlled. She has been on apixaban for her AFib, 1 baby aspirin per day, as requested for her GI doctor due to a family history of colon cancer. She's admitted to the emergency room having fallen on her patio. She has an obvious proximal humeral fracture with impaction at the shoulder and a distal ulnar and radial comminuted fractures. Focal penetration of the skin is noted on the radial side. An orthopedic intervention is needed and desired within 24 hours. Take some time to think and share ideas. How might interdisciplinary and patient-centered PBM strategies be utilized for this patient? What options are available for preoperative, intraoperative, and postoperative assessment and intervention? What could and should be considered? Note on the slide, some strategies are given for all phases of the patient's hospital stay and beyond. Liberal use of transfusion does not provide better outcomes for patients. A dose response could be seen with intraoperative blood use, increasing the risk for wound infection, length of stay, and mortalities. Studies show increases in serious infections in transfused patients. Patient blood management initiatives can decrease risk and potentially prevent these poor outcomes. Certainly, SABM would be remiss if we did not thank you, our industry professional colleagues, for your ongoing support via your research, new technologies, and your partnership. SABM hopes you will find our resources helpful as we continue to expand the principles and practice of PBM. Thank you so much for participating in this presentation.